Thank you. Let me just share my slides. Okay, can everyone see them?
Yes, they look good.
Okay, great. So thanks so much for having me here today. And I appreciate the introduction. I'm Long Roche. I'm one of the GYN oncologists at Sloan Kettering. And I'm going to be talking about one of my favorite things to talk about, which is surgery for patients with and at risk for ovarian cancer. So advance. So to outline my talk today, before we go beyond the basics, I'm going to review a couple of the basics about ovarian cancer surgery. Then we'll talk about surgery in the upfront setting. And when we say upfront, we mean after initial diagnosis of cancer. Then I'll talk a little bit about the role of surgery in the treatment of recurrent ovarian cancer, some exciting and very novel concepts in surgery for ovarian cancer, and then how we can use surgery for prevention. So where do we stand with ovarian cancer in the year 2022? Well, this year it's predicted that there will be almost 20,000 new cases of ovarian cancer in the United States. And unfortunately, we will lose almost 13,000 patients from this disease this year. I put the numbers for uterine cancer up as well because I think it's important to see that even though there's many, many more diagnoses of uterine cancer, the death rate is about the same, just showing that ovarian cancer remains a difficult cancer to cure for many patients. The risk in the general population is about 1.5%. This is contrasted to the risk in patients with genetic mutations, which can be up to 50% over a lifetime. Unfortunately, ovarian cancer is usually at an advanced stage when it's diagnosed. And the reason for this is that we still do not have a screening test, and there are rarely symptoms of early stage disease. And surgery through this remains the mainstay of prevention and treatment. It's important to note that ovarian cancer is not just one disease. However, the most common type of ovarian cancer is high-grade serous carcinoma, and this accounts for almost 80% of all ovarian cancer diagnoses. And as you can see, this is the one that is most likely to present when the disease is stage 3 or stage 4. So a little more about the basics. Terminology is very important when we're talking about surgery for ovarian cancer. So I wanted to highlight a couple of the common terms that we use. Risk-reducing surgery is surgery that's performed in a healthy patient who is at risk for developing ovarian cancer. This is often done minimally invasively and can involve removing the ovaries, the fallopian tubes, and sometimes the uterus. Staging surgery is surgery that is performed to determine the extent of cancer spread. This is performed at the time of cancer diagnosis or soon after, and it can include biopsies of normal appearing tissues and lymph nodes. This can be done minimally invasively or via an open incision, and should be done by a GYN oncologist. Finally, debulking surgery, which I'll talk a lot about today, is surgery, which is surgery to remove ovarian cancer which has already spread or metastasized. This can involve resection of multiple different organs. It's usually done with an open up and down incision and can be performed by a GYN oncologist, sometimes along with other surgical specialists. And there are various types of debulking, and this relates to at what point in the disease course these surgeries are being done. So what about debulking surgery? Why is it so important? Well, we know that removal of all visible and palpable cancer at the time of debulking surgery is the most important modifiable prognostic factor we have for our patients. So in patients who have all the visible and palpable disease removed, so there's 0 millimeters of measurable disease left, those patients have the best outcomes. Optimal debulking refers to removing all the cancer that is bigger than a centimeter, only leaving small spots behind. And as we can see in this graph here, those patients do well, but not as well usually as the patients who've had complete debulking. And then finally, suboptimal debulking is when the tumor cannot be removed and disease is left behind that's greater than 1 centimeter. I always tell my patients, sometimes these patients still have excellent outcomes, although when you look at the curves, this is not as good of a prognosis. Ovarian cancer is a peritoneal surface disease. So it goes on the linings of the abdomen and on the surfaces of the organs. So during debulking surgery, common procedures may include removal of the gynecologic organ, removal of the omentum, which is a fatty layer of tissue that hangs off the colon resection, removal of the spleen, stripping of the lining of the abdomen, removal of lymph nodes, and sometimes a temporary ostomy bag. So moving on to beyond the basics, when we talk about upfront treatment, 20 years ago, we used to tell patients that we have debulking surgery and we have chemotherapy. Well, the landscape for this has changed significantly in the modern era. Now we have debulking surgery followed by chemotherapy, sometimes followed by maintenance treatment. During debulking surgery, we can add things like heated intraperitoneal chemotherapy. We can add drugs to the chemotherapy, and then our maintenance drugs like bevacizumab or PARP inhibitors can keep people in remission longer. You can see that this arrow here indicates that while we used to always do debulking surgery followed by chemotherapy, sometimes now we switch the order. This debate as to which treatment to do first, surgery or chemotherapy followed by surgery, is ongoing. Surgery first is called primary debulking. Chemotherapy first is called neoadjuvant chemotherapy, followed by an interval debulking. There have been many trials that have been done, mostly in Europe, that have looked at which strategy is better. And it's important to note, and this is a list here of the 5 major trials that have been done or are ongoing, that they actually showed that both strategies were equivalent, that surgery first or chemotherapy first resulted in similar outcomes. There is some ongoing controversy here, however, because if you look, unfortunately, neither group in many of these trials did as well as patients in our centers here in the US. The survival times were just not as long in either group. The operative times were also very low, indicating to us that maybe patients weren't getting full dose surgery or as aggressive of a surgery that they might get at another center. So the TRUST trial is an ongoing trial that's trying to answer this question once and for all with a lot of surgical quality controls. What we did see in all these trials, though, is that the impact of residual disease or completeness of surgery persisted in every trial. So in every trial that was done looking at chemotherapy first or surgery first, we saw that patients did the best when all visible cancer was removed, whether they had surgery first or chemotherapy first. So surgical effort and surgical quality is absolutely crucial. So moving on to a couple kind of hot topics in upfront surgery for ovarian cancer, lymph node removal. So it is standard to remove normal appearing lymph nodes during a staging operation to determine if cancer has spread. It's also standard to remove any enlarged or abnormal lymph nodes during a debulking. What we don't know, or what we used to not know, is should we remove normal appearing lymph nodes during a debulking? And what about lymph nodes that have become enlarged outside of the abdominal compartment? So thankfully in 2018, a big study was done called the LIONS trial that actually randomized patients with advanced ovarian cancer who had normal appearing lymph nodes to either full lymph node removal or no lymph node removal. And what they found was that there was no difference in survival. So when it comes to debulking operations, if the lymph nodes are normal, they don't have to be removed. Lymph nodes outside of the abdominal compartment used to be an indication that surgery wouldn't be optimal or wouldn't be successful, but this has changed. Lymph nodes that are enlarged outside of the abdominal compartment do indicate stage 4 disease, But now we know, based on multiple studies that have been published, that these lymph nodes can be removed during a debulking operation in order to achieve a complete resection of disease. This is safe and this is feasible, and we do it routinely for our patients. What about the role of minimally invasive surgery for debulking? So I mentioned that most debulking is done via an up and down open incision. Minimally invasive surgery is either laparoscopic or robotic surgery, which is performed through small incisions, which helps the patient to have a faster recovery. Well, we know for staging operations and ovarian masses that this is very helpful technology. We know that sometimes we do laparoscopy just to gather more information. That's called a diagnostic laparoscopy. But we don't know whether this technology is appropriate for debulking surgery. And it is controversial. Even though patients recover better, we don't know whether doing surgery through those small incisions is going to compromise our ability to get all the cancer out. So there has been some suggested criteria for who to consider using minimally invasive surgery for when it comes to debulking. Right now, we're using it in the interval debulking setting or after neoadjuvant chemotherapy has been given. And the criteria that have been suggested are that the CA-125, the cancer marker, has normalized, that there is minimal disease visible on the CAT scan, that there is no infiltration of the omentum, and that you have an experienced high volume surgeon. And there's actually a clinical trial which is underway right now called the LANCE trial, which is looking at using minimally invasive surgery at the time of interval debulking. One caveat about this trial is that not all high volume centers have chosen to participate because of philosophical differences about whether this is the best option. HIPEC. So HIPEC stands for heated intraperitoneal chemotherapy, which is delivered at the time of surgery. This is another exciting kind of area of progress within the field of surgery for ovarian cancer. And the theory is that if you do surgery and you remove disease, and then while the patient is asleep on the operating table, you administer hot, very hot chemotherapy directly into the abdominal compartment, that this will achieve a more successful treatment of the cancer cells than standard chemotherapy in the vein. The theory behind this is that the heat actually increases penetration into the tissues, and that the heat actually makes the cancer cells more sensitive to the damage caused by the chemotherapy. The heat induces the death of the cells, activates heat shock proteins, so the heat itself might actually be therapeutic. So what do we know about HIPEC in ovarian cancer? Well, there was a trial published in 2018 looking at HIPEC during interval debulking. Again, debulking surgery after neoadjuvant chemotherapy has been administered. 245 patients with stage 3, and this is important, stage 3 ovarian cancer, were randomized to either surgery plus HIPEC or surgery without HIPEC with standard postoperative chemotherapy. And what this group found, and Dr. Van Driel is the lead author of this, is that the group that got surgery plus chemotherapy had better outcomes. Recurrence-free survival of 14 months over about 11 months, and overall survival of almost 46 months versus 34 months. And they found that complications and adverse events were similar. So we are using HIPEC at the time of interval debulking in appropriately selected patients with stage 3 disease. So what about HIPEC at primary debulking? So when surgery is done first, before chemotherapy? Well, the results are mixed so far, and some studies have shown that it does not offer additional benefit. There is a trial underway with the same group that published the Van Driel trial in the New England Journal. And actually at Sloan Kettering, we are participating in this study, primary cytoreductive surgery with or without HIPEC. It's called OV-HIPEC-2. So hopefully we'll have answers to that in the coming years. What about for recurrent disease? Recurrent ovarian cancer remains a great challenge, and surgery certainly has been suggested as an important tool in patients with this. So there have been a couple major trials. GOG 213 was a trial that was performed with multiple different centers in the United States. And this was really two questions in one study. So in patients who had recurrent platinum-sensitive ovarian cancer, question number 1 was, if they were not candidates for surgery, what is the role of bevacizumab? And question number 2 was, if the patients were candidates for surgery, what was the role of surgery? Was it helpful? Patients were randomized to either an operation or no operation. The eligibility criteria were that patients had to be at least 6 months from their prior chemotherapy, and that the surgeon deemed them a good candidate for surgery. So it was a very vague inclusion criteria. The surgeon just said, I think this is possible. And this was published in 2019 in the New England Journal, and 485 patients with recurrent ovarian cancer were randomized. 240 of them underwent surgery. 150 of those 240 had a complete resection of their cancer. And what they found, as you can see in these graphs, is that there really wasn't a difference. Surgery seemed to be safe, but it didn't improve outcomes in these patients over chemotherapy alone. In Germany and in Europe, these questions have been asked in a little bit more of a rigorous format than this. So Andrea Dubois is a friend of ours and an ovarian cancer researcher from Essen in Germany, and he's published a series of high quality surgical trials looking at the role of surgery in recurrent ovarian cancer. Who should we do surgery on? How should we select patients? And then, is this better than just standard chemotherapy? So you can see here some of the data that Professor Dubois and his team has published, showing that there is a group of patients that seems to get a great benefit from surgery in recurrent disease. And you can see this blue line is patients who had no residual disease, had a median overall survival of 45 months, which is much longer than in prior studies. And they described some criteria that help us to pick patients. And then importantly, they published the results of their randomized trial looking at surgery or no surgery in recurrent ovarian cancer. And they had some more rigorous inclusion criteria, how to select patients for surgery. So they included 407 patients. There was a complete resection in 75% of them. And they found that there was improved progression-free and overall survival, 53.7 months versus 46 months in the patients who underwent surgery, with quality of life being the same at 1 year. So where I practice at Sloan Kettering, we still consider surgery in many of our patients with recurrent ovarian cancer. And you can see here the Sloan Kettering criteria that we use to select patients. We look at the disease-free interval, how long since the upfront chemo has complete. We look at how many sites of recurrence and whether the patients have carcinomatosis, meaning scattered disease all over the abdomen. And using these 3 criteria, we helped to select patients who we think would benefit from secondary surgery. Well, what about patients who have had a recurrence, been treated, gone back into remission, and have had another recurrence? This is called tertiary debulking or quaternary and beyond. Well, we have in very recent years published our experience with this. And while it's much harder to generalize to say that tertiary debulking or quaternary debulking for a 3rd or a 4th recurrence is the right thing to do for every patient, we have found that we have some patients that have excellent outcomes after a 3rd or a 4th surgery. And so we continue to entertain these in very select patients. What about HIPEC for recurrence? We talked about HIPEC in the upfront setting, that at interval debulking, there's some benefit. Not sure about primary debulking. What about at the time of secondary debulking or debulking at the time of recurrence? Well, we looked at this and we did a randomized control trial at Sloan Kettering where we randomized 90 patients with recurrent platinum-sensitive ovarian cancer to either surgery plus HIPEC or surgery without HIPEC. And what we found that while HIPEC was well tolerated and appeared safe, it actually didn't seem to benefit patients. And patients who had surgery alone did just as well as the patients who had surgery in HIPEC. So we're not currently using this in the recurrent setting. Novel concepts. And this is something that I tend to get very excited about because one of the major things I'm going to talk about is something that I'm currently studying. which is the impact of stress during surgery and around the time of surgery. So we know that surgery causes stress. It causes stress both on the physical body as well as on the mind. And we know and have good evidence that stress is not good for patients with cancer. So surgical stress, or actually physically stressing the body, can increase inflammation. It can increase inflammatory mediators, which can then propagate growth of cancer cells. It can cause damage to tissues, which can then impair healing and recovery in the immune system. And it can increase stress factors like catecholamines, which again can suppress the immune system, which is very important around the time of a cancer diagnosis. So the exciting part of this is that we believe we can mediate a lot of this stress. So we know that stress reduction has proven benefits in patients who are having surgery. We know that certain medications like beta blockers, which are medications that some people take when they have stage fright or performance anxiety, can lower the stress response. COX-2 inhibitors, which are a kind of NSAID, a kind of pain medicine. Various anesthesia techniques like the use of epidural anesthesia during surgery and after, as well as using IV anesthetics as opposed to inhaled anesthetics. All of these medical modifications have been shown to decrease the stress response. Also, patient-centered techniques like mind-body resilience training, working with our integrative medicine colleagues, and music therapy. All of these individual techniques have been studied and shown to have benefits. This graph here is from a study that we published several years back, looking at actually long-term survival in patients who had epidurals during the time of their surgery versus those that didn't. And controlling for all other factors, we found that patients who had epidurals seemed to have an improved prognosis, showing that that kind of control of the stress response during surgery may have lasting benefits. So right now we're running a trial at Sloan Kettering in patients who are undergoing upfront surgery for ovarian cancer, looking at a combination of these different techniques to try and mitigate stress. And right now we're just seeing if this is safe and feasible. Patients who are having surgery for ovarian cancer are randomized to either regular care or receipt of this bundle of interventions, which includes those medications, anesthetic techniques, mind-body resilience training, and music therapy. And we're studying the safety of this, how it impacts stress levels in the blood, how it impacts the tumor microenvironment, the patient's experience of stress, and we're following it. And we're hoping that these things will become a routine part of care so that we can mitigate those negative effects of stress during surgery. And this is the clinicaltrials.gov summary of this trial at Sloan Kettering, which is called the PRESERVE study. Another topic near and dear to my heart is how we can use surgery to prevent ovarian cancer. So we know that about 20% of ovarian cancer is inherited through genetic mutations. And we know that if we identified every woman with a predisposing mutation, that we could prevent about 4,000 of the predicted 20 to 21,000 annual cases in the United States. And we would prevent those cancers through surgery. Now, unfortunately, 80% of patients who will be diagnosed with ovarian cancer will not have an elevated genetic risk. And so we need to think about them too as we're thinking about surgical prevention. A recent discovery in the past 20 years is that while we call this ovarian cancer, and for some subtypes it really is ovarian cancer, but for the most common subtype of ovarian cancer that I mentioned at the beginning of the talk, high-grade serous carcinoma, we actually think that it is the fallopian tube that is the site of origin, that those cells that live in the fimbriated end of the fallopian tube that sits right near the ovary, that's actually where the precancers and the cancers start. And this has shed a lot of kind of exciting light on how we can help to prevent this disease. Well, we know that removal of the tubes and ovaries in high-risk women has been absolutely shown to be protective, that we can bring their sometimes as high as 50% risk down to about 1 to 2%. But removing the ovaries results in surgical menopause, and many patients either can't or don't want to take hormone replacement therapy, and it leaves them having some major impacts on quality of life. So what about just removing the fallopian tubes? Can this be considered as a primary prevention strategy? Well, removal of the fallopian tubes does preserve ovarian function. The tubes only function after the reproductive, or their only function is in conception and pregnancy, and they really serve no function after the reproductive years have ended. So we're currently studying, can we just remove the fallopian tubes as an interval step to ovary removal in high-risk patients? And two trials that are underway are the SORAC trial and the WISP trial. But what about average risk patients? Could we use this concept to try to prevent high-grade serous cancer in patients who are at average risk? And this procedure is called opportunistic salpingectomy. And the concept behind this is that the fallopian tubes are removed at the time of an other indicated surgery. So for example, a patient who's undergoing a hysterectomy for fibroids, they would also have their fallopian tubes removed, even if the ovaries were staying inside. Or a patient who wanted permanent contraception, fallopian tube removal instead of tying them. Maybe even at the time of other procedures like hernia repair or gallbladder removal. Our friends and colleagues in British Columbia have actually been studying this longer than us. And they very recently published the outcomes from opportunistic salpingectomy in patients who were undergoing hysterectomy or sterilization procedures. And in 25,000 women who underwent this procedure, they expected to see about 5 to 20 ovarian cancers. And they saw 0 in this group who had had their fallopian tubes removed. So it's early data. We weren't expecting hundreds of cancers, but going from 5 to 20 expected to 0 seen was very exciting. So we are studying this as well, and we have a collection of teams that are working together to try to see whether we can expand the concept of this procedure, opportunistic salpingectomy, to more patients out there so that we can hopefully put ourselves out of a job. So how do we find the answers? Certainly, speaking to your gynecologist, if you're high risk or think you might be at high risk, seeking genetic testing, speaking to a GYN oncologist like myself, and certainly organizations like SHARE, who I'm very grateful, puts out all of these webinars and educating patients on these different topics. If you go to the SHARE website, there's a really valuable list of links here talking about ovarian cancer, linking to things like the Society of GYN Oncologists, which also has helpful information. You can see the WISP study, which I mentioned, the fallopian tube study is here, and other advocacy groups. And of course, there's just wonderful resources. These are all photos taken from the SHARE website. So I am grateful that I can refer my patients to these various resources. This is the Sloan Kettering Team Ovary. So there's 5 of us, 5 surgeons. There's other researchers and medical oncologists who are part of this team too. And we're devoted to the treatment of this disease, to the prevention of this disease, and to researching new technologies and better surgical procedures. And then of course, thank you to all of our courageous patients and their loved ones who make this work possible for us every day. So thank you very much for your attention. And I am happy to take some questions.
Hi, Dr. Long Roche. Thank you so much for that excellent presentation. And I loved the inclusion of a bunch of our ovarian volunteers. So that was great to see. Okay, now let's start the Q&A discussion. Everyone can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many of the submitted questions as possible, but we may not be able to due to time constraints. So this first question is about HIPEC, and we actually got a question of that submitted in advance as well, but this person is asking about, just what are your thoughts on that for recurrence?
So HIPEC is not something that we use at Sloan Kettering. So it's not something that I have expertise in. I believe that it refers to pressurized intraperitoneal chemotherapy. So And I think it really speaks to the concept of just chemotherapy delivery in general. So we know that these drugs are powerful and that these drugs can kill cancer cells. We've traditionally put these drugs in the veins. Intraperitoneal chemotherapy is when the chemotherapy is placed directly into the abdominal compartment. If we heat it, will it kill cancer cells better? Will it get into the tissues better? I kind of, summarize some of the data there. If we pressurize it, will it get into the cells better? Will it kill cancer cells better? Currently, there is no solid evidence that it will. It is, I think, a proposed new technique that I'm sure some places are researching. And what I always tell my patients is that with any new technique like this, the big questions are, is it safe? Because if it's not safe, that obviously needs to be known before we administer it to patients. And then is it more effective than the standard tools that we have? I don't know if there's any data answering those questions yet, but I imagine that there are people researching it. One other kind of chemo delivery topic that I didn't mention because it's still in its infancy really is targeted drug delivery. So we now, in collaboration with our molecular biology colleagues and our genomic colleagues, can actually take drugs and target them for certain antibodies or certain proteins. So if you imagine a target that can find cells that express MUC16 and CA125, and then you attach a drug to that target. So there are other kind of exciting drug delivery things coming out where maybe we could use different chemical compounds that very, specifically are bringing drug to cell targets. So I think the kind of concept of chemo delivery is exciting, but the pressurized intraperitoneal chemo, I don't think we have good data on yet.
Okay, great. Thank you for that. And then we are getting more questions about HIPEC, but this is specifically about how does a surgeon decide whether or not to use it in interval debulking surgery, particularly at MSK?
Yeah. So we are very strict with regard to giving it to the patient population who has been proven to have benefit. So that is the patient population that was studied in the Van Driel study. And they did have some pretty strict eligibility criteria about age, kidney function, whether there's any hearing loss, and then limiting it to stage 3 patients. Where this gets a little tricky is one of the main indications for neoadjuvant chemotherapy at Sloan Kettering is stage 4 disease. So if patients have unresectable lymph nodes in their chest or any other stage 4 criteria, which can be, cancerous fluid in the chest, cancer in the organ specific, then those patients are stage 4, and we have not yet had a study that's shown that HIPEC is beneficial. So we limit it to the patient population that received it in Van Driel, which is stage 3, and then meeting some other safety criteria. We tend to do a lot of primary debulking when we can. So maybe patients who would be eligible for HIPEC with interval debulking at another center are more likely to get upfront surgery at our center. But we do use HIPEC in the interval setting when appropriate.
Okay, great. Thank you. And so this person, I think they're really just asking, because with ovarian cancer, recurrence is so high anyway, even when, the uterus and cervix and everything is removed. I think they're wondering, why not leave the healthy parts so the cancer has less critical body parts to recur on?
Well, we do try to leave the healthy parts. So during a debulking operation, we really, with one exception, and I'll get to that, we really only remove organs that are affected by the cancer. The exception to that is we do believe that pathologic examination of the uterus both tubes and ovaries and the omentum, which is a layer of fatty tissue that comes off the colon. Sometimes even when the omentum looks normal, it has microscopic cancer in it. So those organs, uterus, cervix, tubes, ovaries, and omentum, we almost always remove so the pathologist can examine. But in terms of the other organs I mentioned, the spleen, the peritoneum around the upper abdomen and the sides of the abdomen, parts of the colon, the gallbladder, the lymph nodes, if those tissues are visibly and palpably normal, we do not remove them.
Mm-hmm. But typically, even if they come up clear, you would still remove like the reproductive organs.
So there is a role for fertility sparing surgery in some diagnoses of ovarian cancer. So we always want to make sure we have kind of a reason if we're going to modify the standard approach. So in a patient who wants to become pregnant or who's very young and would benefit from hormonal production from the other ovary, in specific cases where we do have very early disease, we found we do sometimes leave those other organs.
Mm-hmm. Okay, that makes sense. Thank you. So this person is asking, would you consider surgery for recurrent disease within the first 6 months after surgery? So someone who's has platinum resistant disease.
Yeah. We always have to ask ourselves the question, because we can do surgery in many cases that we shouldn't do surgery. And that is the question that we have to ask ourselves in those situations. Is the surgery going to be more beneficial than an alternative treatment plan? So I would say that in the first 6 months from platinum-based chemotherapy, there are exceptions to the rule. So there are exceptions if we see that there's one spot and everything else looks good, or if this particular type of ovarian cancer, there's not a good chemotherapy option, then certainly we do break our own rules often. However, if the cancer recurs that quickly after chemotherapy has finished, the risk that we run in doing surgery is that we actually delay the treatment that they really need. So many times patients in those situations really need a chemo switch. They really need a different chemo drug. And if we do surgery, it may actually just delay what is the better treatment for them.
Great, thank you. So let's see. Okay, so this person is asking, what was the mind-body training you mentioned? Is it meditation?
Yeah. So I am the PI of the study, but I am not an expert in mind-body resilience training. So we work very closely with our integrative medicine colleagues, and patients actually will see them for a consult for mind-body resilience training. And I do believe that meditation and kind of connection is a large part of it. And I wish I could speak to it more, but I would have to defer to them in exactly what happens during those consults. But I do believe it's a lot of meditation and kind of some positive imagery and visualization and kind of connecting the mind and the body during a cancer treatment.
Great, thank you. And then we're getting a few questions about the new imaging drug that was recently approved, I believe in the fall. And so people are asking, whether you can provide more information on paflocinine. Did I say that right? Or close?
Yeah,
what your thoughts are on it, and whether this is something a patient should ask about when they consult with their healthcare provider.
Yeah, and there's a couple different companies that are making drugs that are it actually is a lot of overlap with the concept that I mentioned earlier about targeting a cancer cell with a molecule, with a compound. So if you can target a cancer cell with a particular molecule, you can do a lot of different things with that. So you could attach something that is fluorescent to that molecule, which is what some of these compounds are doing, right? So you attach a fluorescence, and then that molecule finds the cancer cell, and then you can use different light technologies, and you could make that cancer cell light up, and you could see it using different light waves. That's very similar to if you attach a drug to it, and then that molecule finds the cancer cell and delivers the drug. The technology is going to be super exciting. We don't know where it's going to have the most utility. And one of the things that comes up with this, intraoperative imaging with these compounds is that seeing the cancer is not usually the hard part. And unfortunately, this kind of speaks to when we're diagnosing these cancers. Unfortunately, we're diagnosing them when they're already advanced and they're plainly visible to see. And so most patients who come into the operating room have to undergo 6, 8, 10-hour operations just to remove what we can see and feel. So the added benefit of something that could see further than that, we're not sold necessarily on that yet. However, it may have some really exciting utilities in finding lymph nodes in patients that have otherwise normal appearing abdomens, or maybe at the time of interval debulking where patients have had a really good response and we're looking for a couple areas which might still have living cancer cells. And what I would tell you is we are studying it, and we do have some studies ongoing at MSK looking at this. We haven't so far found where we think it's going to be the most helpful. But I think the technology is exciting. I think it's a good conversation to have with your surgeon.
Great, thank you. And then, so we're getting a question about whether low-grade serous ovarian cancer and peritoneal patients were included in the studies about the effectiveness of the surgeries that were tertiary and beyond. And then there's also a second part to their question about whether there is any special surgical news that you know of relating to the rare subtype of low-grade serous.
Yeah. So it's a great question. And I didn't go too far into it, but low-grade serous is a rare subtype of ovarian cancer. It sounds like high-grade serous carcinoma, but it really is a different disease. And what we know about low-grade serous cancer is that surgery is even more important. So in those studies, we have published studies, and we have absolutely included patients who had low-grade serous carcinoma in many of the published reports that we've done looking at surgery. And actually, some of our patients who have undergone the most number of cancer operations are patients with low-grade serous. And part of the reason for that is that low-grade serous cancers, oftentimes, not always, but oftentimes they're slower growing. They are likely to recur, and there's not a ton of chemotherapy drugs that work really well for them. So we do tend to come back and do surgery again and again and again. And we have many patients who have, gained years of life with repetitive surgeries. There are some new drugs, and I know this isn't a lecture about drugs, but there are some new drugs and targeted therapies for low-grade serous carcinoma. So we do work very closely with our medical oncologists in kind of when to offer surgery and when not to offer surgery to a patient with low-grade serous carcinoma.
Great, thank you for that. And so we are getting a question about whether scar tissue impacts someone's candidacy for future surgery. And then are there other aspects within our control that make us more ready for surgical intervention? So it's sort of a two-part question.
Yeah, it's a great question. Scar tissue absolutely can impact surgical risk. And so the more operations someone has had, or the more intra-abdominal conditions that cause scar tissue. So multiple operations, open surgery causes more scar tissue than laparoscopic or minimally invasive surgery, but also things like infection in the abdomen, if people have had abscesses in the abdomen or fistulas, all of these things can dramatically increase the risk of doing more surgeries. In some patients, that increased risk may affect their candidacy for surgery. So if a patient has such high risk based on scar tissue as well as other risk factors, maybe surgery wouldn't be the chosen step. I would say that scar tissue alone rarely deters us, but it is definitely something that can impact risk. And if you imagine, organs being super glued together and having to separate them without causing damage, it can be very difficult. What can patients do? Well, there's a lot of attention right now on a concept called prehabilitation. So prehabilitation is kind of, I guess, the twin to rehabilitation. So rehabilitation is when something makes you deconditioned or weak and you get stronger. Prehabilitation is when you get strong in preparation for something. And so for our patients who are having neoadjuvant chemotherapy and planning interval debulking, we are actually getting more into studying whether referral to physical therapy colleagues and nutritionists can prehabilitate them to prepare for surgery. Unfortunately, advanced ovarian cancer, that we're operating on right away, we don't have enough time for that. So we meet patients and they got sick so fast, we have to get them to treatment so quickly. But in general, what can patients do? Don't smoke, because smoking makes surgical recovery harder and it impairs wound healing. Fitness. So it's not, I say it's never just pounds on the scale, but it's fitness and maintaining a healthy body composition will make surgical healing better and will make surgical recovery quicker. And then again, just going back to stress and kind of trying to seek coping mechanisms to modify stress as one is preparing for surgery.
Great, thank you. And it's sort of related to that question, but I wanted to ask about sort of comorbidities and sort of how that impacts surgery, and sort of, is there anything that patients can do with comorbidities to kind of, hopefully have better surgical outcomes?
Yeah, I mean, some comorbidities are out of our hands. So age, for example, when we meet a patient who's 90, we don't usually consider surgery first. We almost always do neoadjuvant chemotherapy first because the risks are too great. Things like getting a blood clot, out of our control for the most part leading up to diagnosis, although we do use blood thinners after surgery often to prevent that. The most modifiable comorbidities are things like BMI, where patients can really work to achieve a healthier BMI. Cardiovascular fitness, being able to walk up and down stairs and around the block and keep the heart and the lungs fit. And then management of diabetes, so keeping the blood sugar in a healthy range is also a big deal, because as I mentioned, these surgeries can involve removal of multiple areas and big incisions, and we haven't helped anyone if they have, if the surgery results in poor wound healing or bowel leaks or other things that can be really terrible.
Great, thank you. So this person is asking about the mind-body study you mentioned again, and just yes, the first question is it still recruiting, and if so, how can people apply to participate?
It is right now it is recruiting. It is a small study, and right now, just because of how it's actually very hard to put it all together, it took us almost a year just to design the study. Wow. Right now, we are offering it to patients who have a new diagnosis of ovarian cancer, who are going to have an upfront surgery, so who are going to have primary debulking surgery. Okay. And so, if there's someone on the call listening who has a new diagnosis of ovarian cancer and wants to have their surgery with us, come in, we'll talk to you about the PRESERVE trial. but it is for that very specific group right now. But we're really hoping that by doing this study, we'll see that it's safe and feasible and that there are benefits, and we can start to expand it to larger numbers and maybe one day have it be as standard of care as things we do to prevent infection and things we do to prevent blood clots. We'll have our things that we do to prevent stress.
Great, thank you. And now we're getting some questions that are not surgery related, but I think, these are what people are asking. So this person is wondering if prognosis depends on, how quickly the CA-125 decreases after chemo.
I would say that this is one of those questions where I will give you the general answer, but my caveat is that there are absolutely exceptions to this rule. So when I say this, I don't want anyone to think that there's not exceptions, but in general, if we see a rapid decline in the CA-125 with treatment, that indicates that the cancer cell is more sensitive to the chemotherapy and does tend to correlate with improved prognosis. However, CA-125 is a very individual marker, meaning sometimes patients have an enormously elevated CA-125 and it's just from one big mass or from the fluid, and even just surgery alone brings it down, and maybe that's not as good of a marker there. But in general, yes, the speed of the decline can indicate a more sensitive cancer cell.
Great, thank you. And now this person is asking about, whether you recommend follow-up for recurrence with CT scans or PET scans or both.
This really speaks to the art of medicine and follow-up. We at Sloan Kettering will use a combination of visits with the patient and physical exams, CA-125 blood tests, and CAT scans. Some providers feel very strongly that they be done at first every 3 months. Other providers feel that if the CA-125 is a good marker from the patient, that the CT scans really should only be done if that CA-125 rises. So it really can vary. In my own practice, the questions I ask myself are, how long has the patient been in remission? So the longer the patient's in remission, the kind of more we let go, especially with things like CAT scan. And is CA-125 a good marker? Because if the CA-125 is a good marker, we might not have to do as many.
Great, thank you for that. And so we only have time for, 1 or 2 more questions. So if you have any last questions to ask, please submit that now. But so this person is asking, and I know you've sort of touched on this throughout, but they're specifically asking, what determines to you the right time to surgically remove a tumor? So whether they get neoadjuvant or adjuvant chemotherapy.
So I always explain it to my patients that there's 2 factors. There is the distribution of the disease, and can surgery physically remove it? And then there is the question of the patient's overall health and fitness. Can the patient endure the operation that I need to do to remove the cancer? And those 2 things are related, and as one changes, the other changes. So in terms of can we resect the cancer, one area that does stop us is when the cancer is involving the entire intestinal tract. So when there is cancer on all of the small intestines, the lining of them or the surface of them, we can't just remove the entire intestinal tract. So even if the cancer is teeny tiny, if it's all over that area, we're not going to succeed with surgery. It may be that we don't see that, but if the operation is going to be 10 hours and involve 2 bowel resections and resection of other organs, and the patient is 80 to 90 years old and has other health problems, we're going to hurt them with that operation. So it really is a team decision. between the surgeon and the patient and their chemo doctor or GYN oncologist, if it's the same person, as to what we think is going to happen at the time of surgery and can the patient recover meaningfully from that. And so the kind of operation that you can offer to a 40-year-old marathon runner is different than the kind you can offer to a very elderly, frail patient.
That makes sense. Thank you.
And surgeon philosophy, that's the last thing I'll say.
Okay.
Some surgeons believe that certain things are doable and others do not. Sloan Kettering, we tend to be a pretty aggressive center. Even though we're aggressive, we still give almost half of our patients neoadjuvant chemotherapy. So even in an aggressively surgical center, you're still going to get a lot of patients who we choose chemo first as the better treatment.
Oh, that's interesting to know. And so I think we only have time for one more question. And again, it's going back to CT scans and PET scans. And this person is asking, which is more sensitive to recurrence?
Usually a CAT scan, actually. It's kind of a misconception that PET scans are more sensitive. The trouble with a PET scan is that nothing will light up that's small. So if something's less than a centimeter or less than 8 millimeters, it's not going to show up on a PET scan. So a good CAT scan that tends to be more precise, read by a good radiologist, and I cannot emphasize that enough. These scans are almost only as good as the radiologist who reads them, just like a pathology report is only as good as the pathologist who reads it. But in our radiologist's hands, who are excellent, CT scans are usually what we would choose as more precise.
Great, thank you. And I think we could do a whole program on scans, which is definitely on my radar because I know there's a lot of questions about that. Well, thank you so much, Dr. Long Roche, for today's extremely informative program. I know that I learned a lot. And thank you to everyone who participated and submitted all of these excellent questions. Make sure to check out our upcoming ovarian programs, which you'll see listed here. Feel free to share these programs with your communities. Your friends and family are all welcome to attend. You do not have to have a cancer diagnosis to attend a webinar. And make sure to follow us on social media as well for all the latest updates. We ask that you please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be sent to you in a follow-up email. All surveys are anonymous, and we really appreciate your feedback because we use that to inform and improve our programming. And this concludes the webinar. So thank you again, everyone, and thank you, Dr. Long Roche.